Good morning. My name is Gautam Kumar from Emory University in Atlanta. I am going to be introducing my case, which is a 52-year-old male who presents with chest pain. And this was unrelieved by nitroglycerin, and he has had 3 episodes of this chest pain in 2 days. He has a past history of coronary artery disease with myocardial infarction 3 times with 3 PCIs, all done in multiple hospitals in this area. Diabetes, hypertension, hyperlipidemia. As you can see, he is on very good medications. There is no issue there. ECG does not show any ST elevation or T-wave inversions. Troponin I was 0.03, just at the border. So we had the diagnosis of unstable angina. We brought him to the cath lab. And you can see the images of the left coronary artery on the top in caudal view and cranial view. Showing moderate disease in both the circumflex and the left anterior descending artery with heavy disease in small diags. And in the right coronary artery, there is a lesion in the distal right coronary artery, which appears to be inside a stent, or it's a little hard to see in this view, but it is inside the stent. Anyway, the operator at the outside hospital elected to do IFR of this, which was 0.93. Subsequently, he then did FFR, which was 0.69. Based on the fact that this was the only lesion the patient had that looked significant enough in a large epicardial artery, he then elected to proceed to PCI of this vessel. He pre-dilated this distal RCA instant restenotic lesion, which was thought to be at the edge or close to the edge of the previous stent, with a 2.5 by 12 Trek balloon at 12 atmospheres, and then stented it with the 3.0 by 15 Zions at 16 atmospheres. And as you can see, there's a little bit of waste in that balloon, which was recognized by this operator. And you can see the overlap stent there with the little waste. And so he then elected to post-dilate this with a 3.25 by 12 NC Trek at 30 atmospheres. And as you can see, the waste still persisted. He subsequently tried a 3.5 balloon and had a similar result as well. At that point, he decided to perform intravascular ultrasound. And I will have Prof. Akiko help us with this. This is a relatively short run from the outside hospital that we got.
Sure. Even short run, it's very clear message. It's very small stent area. And looks like almost same size of the IVUS catheter. So this is Volcano IVUS catheter. So should be the stent area could be like less than 2 square millimeter, which is super, super small. And we have to identify what is the reason. And you can see the calcium behind. And you can see the concentric plaque behind. So probably start from the beginning. In terms of the first stent, it was underexpanded due to the calcium behind stent and concentric plaque. And then second stent was also not expanded. So truly, this is underexpansion due to the calcium.
Absolutely. That is what the operator believed as well. But however, he had taken NC balloon to 30 atmospheres, and he had not had success in expanding this, but he recognized that he needed help. This was the final angiographic result that you obtained. And I think our panelists can also see that there is still some waste on this balloon, on this stent, I'm sorry. And at this point, given the suboptimal PCI result, he was referred to us. And I would, we got this patient around 6 weeks later, but I would want to throw the question to the panel: after a fresh drug-eluting stent, what is the minimum duration and what are the different therapeutic options, gentlemen, that you would be able to think of at this scenario?
So we have Dr. Vincent Luke here. So what about in Hong Kong, Vincent? So how are your strategy?
Hi, I think this is a very good case illustration. And of course, I think the second part of the story is even more interesting. But at this point, I think in the second PCI, I mean the stent we just put in, we can all agree that In case of ISR, then it's very important for intravascular imaging because we need to know the mechanism. In case of ISR, is it atherosclerosis or is it the first case having an expansion stent? And now, of course, with the stent in and make your life more tough for you. To me, the question is how soon now we intervene. I think because the stent was just put in and it is a drug-eluting stent with all the drugs there, I might closely monitor the patient and I'll go in only when the patient have the symptoms again. That's my approach. Of course, I can see that the stent is under expansion, but yet is not really bad. So I know that the chance of ISR is high, but my impression is the flow is still okay. So I might wait until the patient to have more symptom or to do re-angio maybe 3 to 6 months later. That's my feeling.
Great, thank you, Vincent. So, Dr. Kim, what about in Korea in this kind of situation? Do you intervene faster or you will delay?
Yeah, I think it's already put the stent in the very calcified lesions. So I think it's just a post dilation or a very hot is a big diameter of NC balloon does not function at this moment. So I agree. Is another Hong Kong friend is. If the patient suffer the symptom at this moment, I decide to approach some bypass surgery or something more aggressive PCI, something like a stent abrasion, something like that.
All right, thank you very much. So Gautam, please go ahead.
Perfect. So he was referred to us, and 6 weeks later he returned. He was still having some chest discomfort. We were obviously not sure whether it was related to this or whether it was diffuse disease. But in any case, we decided, okay, there is a nidus here. Let us go after this. Let's see what we can do. This was done around August or September of last year. As you may be aware, the shockwave coronary balloon was approved by the FDA for use in the United States, probably around end of February or March. Is that probably right, Prof. Akiko? End of February,
Yes.
March? Yeah.
Yeah.
So prior to that, in the United States, we didn't have the coronary shockwave balloon. So we had to use the peripheral shockwave balloon off-label in this vessel. So we managed to get a 014 Ironman wire down this vessel with a very supportive guide and managed to get a 40 by 40 peripheral shockwave balloon, which is the shortest, smallest balloon that was available at that time, down this vessel. On the image on the right, we are doing 2 atmospheres, 40 pulses. And at that point, when we inflated to 3 atmospheres, there was rupture of this peripheral shockwave balloon, resulting in dye staining and contrast that is now extending almost to the proximal right coronary artery. And this is obviously a scary moment for both myself and my partner, who were scrubbed on this case together. And this shows the balloon rupture with extrusion of contrast pretty much at the balloon. Now, I know in Asia you've had more experience with shockwave. Very quickly, how often do you see balloon rupture with the coronary shockwave in Asia?
I don't know. I don't have experience in Indonesia. I don't know whether Hong Kong maybe. Vincent?
Yes, we do encounter some perforation or rupture of the shockwave balloon, but mostly it's after several shocks. So initial, like the first 4 to 5 run is okay, but now like 6 to 8 run, then probably after repeated inflation, then is more prone to rupture. So some of my colleagues going up to less pressure, maybe, they will recommend you go up to 4 atmosphere. Some of my colleagues go up to just 2 for the initial 4 runs and go up higher to 4 in the, the second half of the inflation. But then I have a short question. So when you see the rupture or the extension of the hematoma, do you think it's due to the shock wave that was given, or is due to the the hydraulic pressure when you rupture the balloon? What do you think?
Perfect. We'll talk about it in a second. There's a number of different mechanisms for this. There is a couple of different possibilities. Yes, it can be due to the hydraulic jet. As you can see, you have a nice little hydraulic jet here. Our balloon rupture happened at 2 atmospheres. We never made it, 3 atmospheres. We never made it higher than 3 atmospheres. And this was our first, this was our first area that we treated. Now, subsequently, we've had a few ruptures with the coronary shock wave as well. And they have been generally with more treatments. And also the other thing is we are treating, at least for the United States purposes here, we are treating calcium behind the stent. So that is actually an off-label application as well, because the approval for shockwave is more for de novo, as those of us who use it are aware. So there's some flavors there. But yes, it could be due to hydraulic dissection behind the stent, or it could be fracturing of the media resulting in blood, or in this case, contrast being able to extrude through the media behind the stent in this case. Because for example, in this patient, he actually has stent in most of the proximal RCA except the ostium. And we will study this shortly. And so at this point, my partner and I didn't really take too many pictures. We disengaged, we kept our guide disengaged, just took a little puff to ensure there was flow, went back in with a new coronary shockwave balloon, and we retreated the area of underexpansion of the stent because that was our goal there that day. After doing that, you could see that there is now dye staining in the sinus of Valsalva with a little bit of contrast extending there, and you're able to see that. At this point, we did, as I said, we did 2 atmospheres, 120 pulses, up to 5 atmospheres. We were able to then expand a 40 by 35 NC mosaic at 12 atmospheres without a problem. So that balloon was able to fully expand, and you can see that, which we had never had till that point in time. So at this point, we decided to stop here, and this is an angiogram and intravascular ultrasound, and I will have Prof. Akiko comment on this as well.
Sure. Okay, let me request remote control. I do remote. Okay, so yeah, but I think there is not much explanation. It's really, so you see
from the beginning again.
Yeah. So this is a distal to the stent. You see the a little bit nodular calcification, but that's okay because Luma is good enough. And then this is almost relatively normal segment. First, you have to check the no edge dissection. It's no dissection, that's good. And then you see the old stent, but it's no explanation at all. You see the stent was super. This is a place we see the super under expansion. You remember the double layer of the strut and also the calcium behind. And that's, I think now is almost like the over 7-8 square millimeter, which is almost like the, wow.
So we have done good there.
Yeah. So I think it's not many explanation. It's just like good expansion. But if you want to say more detail, meaning that because what is the mechanism, you have to make the fracture behind stent. But it's really fracture everything. This is you see the calcium behind stent. But this case, because it's very well fractured, and I really don't see any calcium fracture to say in this picture, but anyway, it's very good expansion. Yeah.
And as we get more proximal, now this is the proximal edge of the stent, and I will pause it for you here, Akiko, so you can tell us about what you're seeing there.
Yep. So starting here, there is a very funny findings, meaning that currently he's picking up, that's at 3 o'clock. There is a dark area, which is outside of the intima, right? And also a little bit like 10 o'clock, or you can move a little bit more. Yeah, you see the dark area. And most likely that is a contrast staining, or could be the blood. And then go more. And here is even more clear. You see the 3 o'clock, and then jumping the proximal to the stent? Oh,
I'm sorry. Let me see if I can get it back. Okay, here you go.
yeah. So this is exactly edge of the stent. And now you see the, let's say start, yeah, that's a place. You see again the dark area. This is really outside of the intima, meaning that should be either inside of the media or probably mediator adventitia, some of those space making the intramural hematoma, which I show in the my presentation. And you see the, yeah, so that's very clear hematoma. That's indicating what we see by, yeah, even this is more, you see the hematoma top, that's very clear. So that's very typical intramural hematoma. Typically, the intramural hematoma is hyperintensity and helmet shape that's pushing to the lumen. And the importance of this case was extended through the behind the stent, which we can recognize by dark area, which could be the blood or contrast, that's extended to the outside of the stent, close to the ostium. So now it has to be covered, and that's explaining what see in the angio.
So we have had some experience with this phenomenon. I have seen a similar appearance both with orbital atherectomy, where I once had a perforation that had a very similar behavior. And we have seen a few of these with intravascular lithoplasty as well. So, we are seeing this both with IVL. So I figured, this is something that's interesting that the panel and the audience might want to know. Any comments from the panel as well?
Yeah, any comment with this? Maybe lead motion, Harry, do you have any comment regarding this?
Yep. Just like the Professor Akiko has said that we after you fully expanded the stent, previous unexpanded stent, but there's a proximal side still has some intramural hematoma. So I think for me that we should definitely cover the new stent all the way to the ostium. I think will be safe for the patient. That's my opinion.
Yes. So we identified this, and just like the panel said, we were able to identify this, and we decided to put a new stent that covered it all the way into the aorta. Notice that we are using an Amplatz guide here. So for the more junior operators, we disengage this guide to ensure that we are coming into the aorta with the stent. Very important technique, because an Amplatz will generally tend to engage deeper. And this is after deploying the stent. We then went with a flash balloon and sealed down the stent. And Prof. Akiko, again, you can comment on the IVUS that is performed through that proximal stent now.
Yep. So I think, as I said in my presentation, what is important is you really have to confirm the ostium was well covered. Now it's close to the ostium. And you see some outside, oops.
Yeah,
I see some hematoma at the very last frame.
Yes,
Can you go to the very last frame?
I think I saw that too. Believe it or not. Let me see. Yes, this is interesting. Let me go frame by frame.
Go to the very, very end. Oops. Yep.
Yeah.
Okay. But I think it's okay, because as I said, typically the hematoma should have the entry side as well as no re-entry side. Yeah. And I do think the entry side, this case, should be the distal, because you make the dissection from the distal to proximal. Therefore, I think you already covered the entry side. Actually, already entry side is behind stent. Yes. So because of the pushing to the lumen, you have to put the stent. But there is one slice I see still hematoma, which may not covered by stent, but that should be okay, because you covered the entry site already, and lumen is big enough.
Yes, and we actually thought that we covered the entire thing up to the aorta, because you can see we were able to disengage and re-engage with this Amplatz guide with no difficulty after the flash. And the other thing is, if you notice, the dye staining in the sinus of Valsalva has also disappeared. There is no more dye stain in the sinus of Valsalva. So calcium behind a stent can be a very difficult issue for us to deal with. With IVL, this is a useful tool in managing this scenario. However, fragmentation of the medial calcium can lead to dissection or perforation even at sites that are remote from where you're treating. And it's important to be aware of where this entrance, like what Prof. Akiko talks about, where this entrance is, so that you can treat the entrance and then deal with what needs to happen to the other remote site. And I think those are important things for advanced operators. Thank you.
All right, great presentation. So I think there's many things that can be discussed in here. So we still have 10 minutes for discussion. So I believe that Gautam already chose a shockwave lithoplasty in this difficult scenario. So I don't know, what about in Japan, Dr. Sugi? Do you do lithoplasty or shockwave in this kind of situation?
Yeah, thank you for excellent presentation. In Japan, so the shockwave is still not available. So we have to treat, when we have to treat such a region, another other way. We have to do other way. So for treating such a region, or very high pressure balloon over 30 to 40 balloon atmosphere, or the stent ablation, and we have the excimer laser. So for such a region, excimer laser with contrast media is it can be useful for such a region, I think. And I know that Professor Maihara reported the feasibility of the excimer laser for such a reason. My question is the indication of the excimer laser bubbling technique for this region.
Are you asking me?
Yeah.
Okay.
Everybody can answer that.
Sure. Yeah. We reported, we compare this type of the cases, meaning we picking up by OCT, we picking up like 30 cases which having the stent and expansion behind the stent due to the calcium behind the stent. And then some of them, operator decided to do the excimer laser with contrast, and some of them was not. And then clearly the patient had such laser, they have the good fracture behind stent, and they're making the good stent expansion. But I do think this is a last resort if you really need it.
Yeah.
But we know that works sometimes. Yeah.
Thank you very much.
Dr. Suki, may I ask you about this kind of lesion? Do you use the lotobrator for correct this under expansion in this situation?
Yes, sometimes we do. Stent ablation is one of the option for the unexpanded stent. And so we do the ablation with a very high speed, rotational speed. And it takes a longer time for the conventional ablation, I think. It's a good indication, I think.
That's great. So Gautam, you use peripheral lithoplasty shockwave. I don't know, is there any different? I mean, it is the main cause, or it's not an issue. I don't know, because we don't have luxury to have lithoplasty shockwave in our country.
So we use the peripheral lithoplasty IVL balloon in this case, because at the time of when we did this case, as I said, the coronary lithoplasty balloon was not available. Like my colleagues from Japan, our approach to this pre-availability of IVL was also high-speed rotational atherectomy with stent ablation strategy and balloon angioplasty and restenting it. The advantage that this potentially gives us is, you have a relatively new stent there, and hopefully, after the first month, your hope is you're able to, month or maybe 6 weeks, when the polymer, the drug is eluted away mostly, you're able to do IVL inside that stent. But I would not do it to a fresh stent that has just been placed a week ago or something like that. That is something that I would not do because that would really be detrimental to the polymer on the stent as well as the drug. The other point is, there are people who have done laser with contrast to try and expand this as well. Again, this depends on what you have in your center. At our center, we don't have laser. And so that's not something that was an easy option available to us during the time of this procedure as well.
Thank you, thank you. So in NUH, Juan. So what do you think? You have both, right? You have laser, if not mistaken, or you have also a lithoplasty right now.
No, we don't have laser in Singapore. It's just a shockwave balloon, yeah, lithotripsy and orbital tracheotomy. But a very nice case, very nice demonstration and things along that line. In situation like that, I think it's like nowadays with lithotripsy, I think it will be my first tools to use when I have a stent, under expanded stent and things. And I think the timing is certainly an issue. I don't know whether you have a OPN balloon in the state, Gautam.
No, we don't have the high pressure balloon.
Right, yes. Just once or twice, I was pleasantly surprised by the under expanded stent, and when you brought patients back, and you just put in the OPN stent, and the stent expanded nicely, so save you all the sort of like what you call gears and timing. You just put in an OPN stent and then it comes up. I don't know whether implanting a stent, it actually causes some form of inflammation process and subsequently make the stent expanded quite nicely. I don't know, but I have one or two cases like that. You bring patients back thinking that you need to take on a more sophisticated device, but just try it using a high pressure balloon, and the stent came up nicely.
So yes. Akiko, you have something to say, Akiko, because Juan mentioned about the OPN, very, very high pressure balloon. With this kind of IVUS finding, do you think it's a good idea to choose the OPN balloon? So is this a 30 or 40 atmosphere, right, Juan? Because we don't have in Indonesia.
Yeah, up to 40. Yeah.
Up to 40 atmospheres.
Maybe now it's higher, I think. So.
It's gonna be good, or any risk of perforation? What do you think, Akiko?
I'm sorry, I don't know. I don't use OPN.
All right, that's
yeah.
okay.
Can I change the questions for Akiko?
Sure.
What is the finding of the IVUS in this Gautam's case to stop doing anything more? Like the first operator, they stopped at the diameter of the stent expansion is just 2 millimeters and sent to him, or let the patient live like that and have a recurrent angina. Do you think what is the limitation of the IVUS stop to do? Because we know that we cannot accept 2 millimeters stent diameter, but what is the IVUS finding for stop? It will be harmful in this situation, in this kind of case, because I face a lot of junior interventionists in my country, do the very aggressive, get the bigger balloon, very high pressure, balloon rupture or vessel rupture is the end of this kind of case.
Harmful. I think we should have the good prediction based on the IVUS. So, for example, if you have the very circumferential calcium, as I said in the first presentation, sometimes it's thin calcium. So if the circumferential calcium is very focal, could be the non-compliant balloon can make the calcium fracture. So that can be tried. Let's say that IVUS calcium showed very circumferential but superfocal, and then geographically not very clear calcium that's may indicating the thin calcium. And then try the non-compliant balloon and then making the fracture, I think they very possible. But let's say very, very severe long circumferential calcium, and then geographically it's almost severe calcium. And then keep trying the non-compliant balloon is almost impossible, or just waiting the perforation, right? So we should have the prediction when you see what kind of morphology, what is the expectation. And very focused circumferential, try, but not react, maybe that's not possible. And if you are very severe long calcium, even non-compliant balloon, I have no idea how make it fracture. If so, without having the rotablator in your hand, it's harmful to proceed to put the stent, right? So that's, I hope I answered the question.
Yeah.
I agree with Prof. Akiko. I think it really comes down to making your first shot your best shot. And, unfortunately, those of us, like many of us on this panel, are practicing in referral centers. And sometimes the first shot and second shot and third shot have already been taken before the patient is even sent to us. And that makes it difficult. But really, I think when we are educating younger practitioners, I think this calcium point scoring is very important. And really, even if you don't know the points, I think the most important point is if you have 360 degrees of concentric calcium, and if you have a significant length of calcium, an atherectomy first strategy should probably be a preferred strategy. Now, if you ask me, I would go one step a little further and say, if you have a lot of medial calcium, in addition to just superficial calcium, if you have a lot of deep calcium as well, you may want to think about some other strategies beyond rotational atherectomy to take care of some of the deeper calcium as well. But that's a separate discussion though.
Great. So we learned so many things in your case, Gautam. Congratulations.